Good day, everybody. My name is Martin Kiernan, and it's my great pleasure to be able to host today's teleclass, which is COVID-19's Challenges to Infection Control DOGMA. Our speaker today is Dr. Michael Klompas, who is a hospital epidemiologist at Brigham and Women's Hospital in Boston, Massachusetts, also a professor at the Harvard Medical School and the Harvard Pilgrim Healthcare Institute. Dr. Klompas is a well-known speaker on many topics, but particularly on surveillance, diagnosis, prevention, and treatment of hospital-acquired pneumonia. And he's recently chaired or co-chaired a group that's produced the SHEA strategies on preventing ventilator-associated pneumonia. He's an amazing speaker on many topics, but also has published a number of papers on COVID-19 during the pandemic. So today's topic is particularly apt because it really is about time we started to look at the challenges to the dogma many of us have stuck with for a number of years. So I'm very much looking forward to this presentation. So welcome, Michael. Please start your presentation.
All right, lovely. So thank you so much. I very much appreciate the opportunity to be able to speak to you today and to share some ideas together. So let's dive right in over here. These are my disclosures, grant funding, and some royalties. And here we go. I want to root this in the experience that we had at our hospital. This was back in September of 2020, so early on in the pandemic, where we had a large COVID cluster. And this was sort of the headline in the local newspaper. It actually went to the New York Times as well. And I'm describing that we had this problem and some of the challenges we faced with it. And as we sort of recovered when the dust finally settled from that event, I wondered, was our experience extraordinary? And so I type into Google, hospital COVID cluster, and of course Google immediately spits out a big chain of similar experiences. So it turns out I think most of us, if not all of us, at some point have experienced COVID clusters. It very much was I think part and parcel of the pandemic experience, and some of us continues to occur to this day. And in fact, if you characterize, it's well known that hospital-acquired COVID infections are common. That's particularly during surges. So whenever there's an increase in COVID inside of the community, there's a parallel increase in hospital-acquired COVID infections. This is a retrospective analysis of 4.4 million hospitalizations across 288 hospitals in the US, looking at the count of hospital-onset SARS-CoV-2 infections, 3 different definitions after day 7 or after day 10 or after day 14, depending which color line you like to look at. But the pattern's the same. And what you can see over here is this clear pattern where there's an increase in hospital-acquired COVID infections that follows community-based increases. In this study alone, they identified over 14,000 cases of hospital-acquired COVID, was present in 0.4% of hospital admissions, and up to 8.2% of COVID census was actually acquired in the hospital. So that's kind of an amazing thought. You think to yourself, every single COVID patient in the hospital, 8% of them acquired COVID in the hospital. So to me, that's a very striking number. And they estimated for every 10% increase in the community incidence of SARS-CoV-2, there was a 3-fold increase in hospital-acquired infections. So clearly, we have a major problem with hospital-based transmission of COVID-19. And it begs the question then, what's up with our infection control measures, and are they up to the task? Do they address that particular need? Because I think the fact that we had so many and continue to have so many hospital-acquired infections would suggest that maybe we're not quite getting it right. So this was WHO guidance back in 2020, sort of the starting point for where things were at. And you recall this very well, right? The basic was that if you're in a non-care situation, you'd be wearing a medical mask alone. If you were caring for a patient with suspected or confirmed COVID-19, but no aerosol generating procedure, then you'd wear eye protection, a medical mask, a gown, and gloves. And if you're caring for a patient with COVID-19 and doing an aerosol generating procedure, then you kick it up a notch and you use a filtering respirator like an N95 respirator or a PAPR as an additional level of respiratory protection. And the question, of course, is, does this do the magic? So that protection set is based upon a number of points of traditional dogma that I think we're going to try to dissect together. Number one, that most respiratory viruses are spread via droplets, and that short-range spread of infection is evidence by induction of droplet-based spread, and if you have long-distance spread, can that be due to aerosols? And so the notion there, of course, would be that if it's spread by droplets, a medical mask alone should be perfectly adequate. Ventilation is not a particular issue. Whereas if it's spread by aerosols, of course, then opposite considerations are going to apply. Number two, A surgical mask provides adequate protection against most respiratory viruses under most conditions. And number 3, selected procedures increase aerosol generation, and these procedures merit higher levels of respiratory protection. And in particular, that would mean either wearing a N95 respirator, a PAPR, and putting a patient inside an airborne infection isolation room, in other words, a negative pressure room with an increased number of air changes per hour and negative air flow. What we're going to do today is we're going to take each one of these 3 points of dogma and we're going to dissect them together. So let's start off with number 1 over here. Most respiratory viruses are spread via droplets. Well, here is an amazing photograph from a researcher at MIT where she's been able to capture in a single image these 2 kinds of respiratory emissions. Shown in green are droplets. Now, droplets, of course, are larger respiratory particles that are felt to be by virtue of size and gravity to be able to fall rapidly to the ground, typically within a radius of 3 to 6 feet or 1 to 2 meters from the source individual. They do not spread far, so localized spread alone. By contrast, shown in red are the aerosols, and these are much finer, smaller particles that are small enough and light enough to remain suspended in the air, to be carried on air currents, to go well beyond 3 to 6 feet, to go well across an entire room, if not beyond. And the question, of course, is which one of these do we produce? And which are the carriers of virus? Well, it turns out, of course, that we are not machines, we're human beings, and human beings do not operate in silos, but rather operate in a continuum. So if you actually measure the respiratory emissions coming out of a person, you'll see it's a mix of particles of all different sizes, from very small to very big. And in other words, there is no hard and fast division between an aerosol and a droplet in terms of one's emissions. It's a continuum. Nonetheless, you will note that the majority of our respiratory emissions are in that finer range, more in the aerosol kind of range as opposed to the droplet range. And it turns out that these aerosols have now, I think it's been well demonstrated, can carry a range of respiratory viruses, not just COVID alone, but influenza, RSV, rhinovirus, MERS, you name it. Turns out that if you sample the air inside of a healthcare center during a respiratory viral surge, you will be able to capture inside the air whatever's going around. So if it's in the heart of influenza season, if you sample the air inside of an urgent care clinic or emergency department, you'll be able to isolate influenza. Likewise with RSV. If you're in an area of the world where there's MERS circulating at the time, you'll be able to capture MERS, so on and so forth. In other words, this idea that you can capture suspended inside the air respiratory aerosols that contain virus is not specific to any one virus, but rather a truism of all respiratory viruses. The question, of course, is just because you can find the air, can these aerosols actually transmit infection? Or is this simply a factor of being able to identify some microscopic amounts of virus that you can only detect using molecular methods that have no sort of clinical impact? So can we actually attribute transmission to aerosol-borne virus? So I'm going to start with some animal studies, and I'll move over to human. So in this particular experiment, what you do is you take a ferret and you infect that ferret with a respiratory virus. In this case, it was influenza or SARS-CoV-2. You put the ferret inside of a cage. You have a one-way system for flow of air, where the air has to go basically through this tube over here, take a 90-degree turn, go up against gravity a full meter, take another 90-degree turn, another 90-degree turn to get to an unexposed or a naive ferret. And you look and see, does the exposed ferret get infected or not? So here's the flow of air. You can see a number of 90-degree turns going up against gravity. There's no droplet in the world that can manage that particular pathway. If you see the exposed ferret get infected, that is evidence of aerosol-borne virus leading to transmission. They did this experiment, and lo and behold, 2 out of the 4 ferrets exposed to SARS-CoV-2 got infected. 4 out of the 4 ferrets exposed to influenza got infected. Now you're saying to yourself, okay, that's very nice, but I'm not a ferret. I'm a human being. I'd like to see what happens with people. Turns out there's a human equivalent to the experiment, and that is quarantine hotels. Now, you remember the situation, right? This was earlier on in the pandemic, where certain countries, particularly along the Pacific Rim, opted to say that a patient coming from abroad has to be quarantined inside of a hotel for 2 weeks to make sure they don't have COVID before we let them out into society and to potentially bring the virus into our broader countries. Now, these hotels were very strict. You had to remain inside your assigned room the entire time. There was video monitoring and human monitors to make sure a person did so. All your food and needs were delivered to the door. So in other words, you were stuck inside that room on a strict basis for 2 weeks. Nonetheless, despite those very strict rules, there was instance after instance from country after country of people getting infected inside of quarantine hotels by the person in the room next door or down the corridor. Now, how could that possibly happen? The thought was that when this was ultimately dissected, was that what happened would be the worker would come along to check on you or to give you food. They would open up your door. There'd be allow sort of a whoosh of air coming out of that room. Then they would close that door, go down the hall, open up the next room in order to check on the next person. And that would allow some of the air with virus from the corridor to get inside the next room. Now, again, there's no way in the world that a droplet could do that. That a droplet can go out the door, hang a left, knock on the next door, go in through the door, right? That can only be an aerosol, something that's going to be suspended inside the air that's able to do that. Now, you're probably saying to yourself, well, hang on a second, though. I mean, this is very nice. But in my practice, it was actually pretty unusual to see people infected from room to room. Certainly inside our hospital, that was very much a rarity. How can we explain the fact that it seemed to be so common inside these quarantine hotels that there was room-to-room based infection of individuals? And again, these were all genetically confirmed. So the thought is this, was that if you're inside of a room for a long period of time, ventilation becomes into play. And in most hotel rooms, the ventilation is not particularly strong. So this is actually a demonstration of that. This was me taking my carbon dioxide monitor to my new hotel room in Atlanta. And because I'm a geek, I carry with a carbon dioxide monitor, and I just happened to see what was the nature of the quality of the ventilation inside that room. Now, carbon dioxide is a proxy for quality of ventilation because as we exhale, right, we put carbon dioxide inside the air. And if the ventilation is not so good, that carbon dioxide is going to accumulate. So look at this. I get to my hotel room at 6 p.m., okay, and you can see a constant and steady increase in the amount of carbon dioxide inside the room. Witness the fact that the ventilation inside that room was very poor. And again, this was a nice hotel, new hotel room, what have you. Bringing home the fact that if you're in a closed space for a very long period of time, you can get large accumulation of whatever you exhale. Now, if what you're exhaling is virus, you can imagine an enormous amount of virus ultimately accumulating inside that room. And I think that's what makes it possible ultimately, that when you go ahead and you open that door, there's so much virus inside the air inside that room that sort of enough gets out into the hallway, then into the next room as you open up the next door to allow for transmission. So this brings home the issue of ventilation. It also sort of teaches us a lesson about the importance of viral load. The more virus you're exposed to, the greater the probability of transmission. And because a hotel room for a person staying in a hotel room for 2 weeks really is an artificial situation, right? Normally we don't do that. But that allowed for extraordinary accumulation of virus inside of some of these rooms, that then allowed for this extraordinary and unusual situation of transmission from room to room. But bottom line, I think this is quite good evidence that aerosols were at play. The other point of evidence that really tells us that about the importance of aerosols was our recognition, particularly early in the pandemic, of the large amount of transmission that was attributable to people without any symptoms or who were pre-symptomatic. I think the CDC estimated that about 60% of COVID transmission was attributable to people with either no symptoms, who were asymptomatic throughout their infection, or who were pre-symptomatic during the transmission phase. Now, again, think about it. If you're asymptomatic, how much droplets are you actually generating? Right? You increase your droplet generation when you're coughing, or you're sneezing, or you're spluttering. But if you're asymptomatic and you're simply breathing quietly, that should be mostly aerosols that you're putting out, not droplets. Now, as I've said already, everything I'm describing today actually applies to all respiratory viruses. This is not specific to COVID. So here is some parallel data from influenza showing that influenza transmission has many parallels to COVID transmission. This was a study of household transmission in South Africa, where household members were tested twice per week by PCR. And the important points over here was that a large fraction of people were contagious despite the absence of any kind of symptomatology. So no symptoms in 44% of individuals. And they estimated that 27% of secondary infections were acquired from asymptomatic index cases. So 7% of infections coming from people without symptomatology. Now, if you do have symptoms, you're more contagious. Sorry, let me get rid of that. If you do have symptoms, you're more contagious, but nonetheless, there's a lot of transmission taking place from asymptomatic persons. So in essence, this is felt to be the way that most transmission is taking place. You have two people who are feeling perfectly fine, who are interacting in ordinary fashion, simply talking to one another. And in doing so, you can see the respiratory emissions coming out of one person is being breathed in by the other person, neither aware that they're infected or that they're transmitting infection, yet nonetheless that appeared to be the basis for a great deal of respiratory viral transmission before people became symptomatic. Now, there are a number of factors that have been teased apart that impact the amount of aerosols that a person emits. This is a study over here looking at the fold increase in respiratory viral emissions relative to quiet breathing. So if quiet breathing is 1, if you start talking, you're going to increase your aerosol emissions 35-fold. If you're exercising, 60-fold. Shouting 164 times. Forced expiration over 200 times. And coughing almost 400 times as much aerosol being put out. And by analogy, therefore, as much virus being put out inside the air, and therefore that much more probability of transmission taking place. We know there's a tremendous amount of variability as well. A lot of people don't put out too much virus, but there's some people just by virtue of their biology, by variation between person to person, will put out a lot of virus. So this is differences in the quantity of influenza virus RNA emitted by 26 people. You see most people put out almost nothing, but these guys put out a ton. You're starting to see over here the elements that might take place, that might be in place for a super spreader event. You have an individual who happens to be on this end of the spectrum in a closed room with a lot of people with poor ventilation, who's shouting or talking boisterously. That's the kind of circumstance that's going to lead to a lot of transmission, and particularly if they're also there for a long period of time. I've said already about the importance of viral load as a predictor of transmission risk. The more virus you're exposed to, the greater the probability of you acquiring the infection. That can be either because there's more virus being generated by the person, more virus being emitted by the person because they're shouting or exercising or coughing, or increased duration of exposure, so that cumulatively the amount of virus you see is more. This particular study demonstrates the association between quantity of virus and risk of transmission by looking at viral loads. So people here who have very high viral loads had a very high rate of transmission, low viral loads, lower transmission risk. But again, we said other ways that can lead to increased exposure. It could be increased duration of exposure, or poor ventilation, or increased emissions due to activity. Now, here's a question that I think caused us a lot of perplexity. If indeed the claim here is that SARS-CoV-2 is spread by aerosols, how come it was actually pretty rare for us to see long-distance transmission events? Most transmissions really took place from face-to-face interactions, not from the person being across the room and occultly transmitting. So why didn't we see more long-range transmission? And the answer is that even with an aerosol-borne virus, that distance is nonetheless protective. Why so? Well, look at this. Here's a visualization of a person's respiratory emissions at 3 feet from the individual. Look what happens if you go out to 6 feet and then out to 12 feet. In essence, what's happening over here is that distance allows for dilution and diffusion, that therefore therefore decreases the amount of aerosol emission, the amount of virus to which a person is exposed to. If you're exposed to less virus, your probability of transmission is going to be diminished. So distance, even with an aerosol-borne pathogen, is highly protective because of the factors of dilution and diffusion. Here is some, again, data. This one's coming from influenza, looking at the impact of distance on viral recovery. You can see over here, the further away you are, the less and less virus that you're going to be able to detect from that individual. This is my favorite study of the entire pandemic, bringing home in a single study the importance of both distance and time as either risk factors or protective factors. So this particular study was done in China, and they identified 2,300 people with COVID and 72,000 close contacts who all rode the train together. And they were able to then characterize by linking together people's train records, where they sat in the train, and their medical records, did they get COVID, to characterize the actual risk of transmission as a function of distance and of time. So if the index patient with COVID is sitting here, and you have the misfortune to be sitting right next to the individual, you had a 3.5% chance of getting COVID. If you're merely 2 seats away, 1 meter, your risk of transmission dropped literally in half to 1.7%. If you were 2 seats away, it went down almost another fifth of that amount, down to 0.4%. So you can see the profound protective aspect over here of distance leading to less and less transmission. Likewise, because these are train rides, you could also characterize the impact of time, right? You knew how long the train journey lasted. So here is your risk of transmission as a function of duration of exposure. If you're only exposed together for an hour or two, your risk of transmission was tiny. If you went up there to 8 hours, your risk of transmission increased about tenfold. And again, why? Because the more time you're exposed to a person, the more cumulative quantity of virus you'll be exposed to, and therefore the greater probability of transmission. We've spoken about a little bit about the impact of ventilation. Let me just summarize the key findings over here. And ventilation is protective because it allows for more diffusion and dilution over distance. And so if you're in a well-ventilated outdoor area, the only person who's really at risk of getting COVID from another person is somebody who's in their face. If you're literally face-to-face interaction, and that's because with a face-to-face interaction, there simply is insufficient space to allow for dilution and diffusion to take place. So if you're face-to-face with a person, even in a beautifully ventilated area, you are still at risk. By contrast, if you're in a poorly ventilated indoor area where there's enough time for virus to accumulate inside the air, it'll eventually accumulate throughout the entire room such that everybody inside the room is at risk of transmission. The importance of time was brought home to me in an experience in our own hospital where we asked the question, what happens if you get admitted to the hospital to a shared room and it just so happens that the person in the bed next to you is an unrecognized COVID case, somebody who's in that asymptomatic or pre-symptomatic phase and whom you do not know as COVID? What's your risk as a roommate of getting infected? Now, remember, this is a hospital, so we do have good ventilation. We have at least 6 air changes per hour. And yet, despite that decent ventilation, we found that amongst 25 patients with COVID and 31 exposed roommates, that almost 40% of them, 39% to be precise, exposed roommates got infected. And that's despite being 7 feet apart, a curtain in between, and 6 air changes per hour. So how could it be that nonetheless there was transmission? And the answer, of course, because people in a hospital room are spending a large amount of time together. The median duration of exposure here was 18 hours, and in some cases far beyond that. And that was what we think is what accounted for the high rate of transmission, despite good ventilation and being more than 7 feet apart. So this really brings us back to where we as medicine were over 100 years ago, which is recognizing the importance of good ventilation. So here's a sign from the early part of the last century. Keep your bedroom windows open to prevent influenza, pneumonia, and tuberculosis. And one of my favorite pictures over here, an outdoor ward in London during the First World War. Again, an appreciation of the importance of good ventilation, good fresh air to help in not only recovery, but also in decreasing transmission from person to person. Okay, point of dogma number 2. Surgical masks provide adequate protection against most respiratory viruses under most conditions. In other words, how good is your medical mask? Let's start again with an animal study, and then we'll move over to humans. So this one is done with golden Syrian hamsters who put inside adjacent cages with and without tightly fixed surgical masks. So what happens if you have the index patient who's infected with COVID? You have a number of naive, uninfected golden Syrian hamsters. You have a one-way flow of air. If you have no kind of masking or protection at all, you can see 67% of the exposed golden Syrian hamsters got infected, so that's 2/3. If you put a mask over the cage of the source golden Syrian hamster, you could decrease transmission down to 17%, so a substantial decrease. Likewise, if you put a mask over the exposed, you could also decrease transmission, not quite as much, but nonetheless, still a decent increase. And so you can see over here the protective power of a mask. And even with a regular medical mask, you can get a substantial decrease in transmission because you're basically blocking some degree of aerosols. You'll notice, though, that in neither instance do you have perfect elimination of transmission. And why is that? So before we get to that, I just want to show you that there is a human equivalent to this observation. This was an analysis of 969 close contacts of 431 people with COVID-19 in Johnson County in Iowa in the United States, and look to see what was the risk of transmission as a function of masking. And if neither party was masked, neither the infected person nor the exposed person, the rate of transmission was just under 30%. If one person was masked, you brought it down to about 20%. If both people were masked, you brought it down to 12%. So you can see again here, the protective power of just a regular, ordinary medical mask, it substantially decreases risk of transmission, but does not eliminate it. And again, the question is why? And the answer is because a medical mask provides some degree of decrease in aerosol emission, but does not provide 100% elimination. So this is a technical characterization of that, where you measure particle penetration behind a mask. So what you do is you have a person put the mask on, and you have them do a number of normal activities like move your head side to side, talk, move your head up and down, read a passage, and you measure the amount of penetration of particles behind the mask. And you can see over here that the mask did decrease the amount of particle emission a fair bit, but did not eliminate it. It took the overall amount of emissions down by about 38%. And turns out this is consistent across studies. A medical mask will reduce emissions by around 40 to 60%. So that's good, but it's not perfect. And indeed, we've been able to see that this does play out with a benefit in decreasing respiratory viral transmission. This is a study asking the question of, did our masking practices during COVID have an impact on the acquisition of influenza or RSV inside the hospital? The idea being that we were doing lots of things to prevent COVID, but one of the things we did was we wore masks. And so you would say that if in fact you buy my proposition that all respiratory viruses transmit in a similar fashion, if we were wearing masks, that should have had an impact on flu and RSV as well. And in essence, what we found was that masking was associated with 50% decrease in nosocomial flu and RSV, even after taking into account the community burden of influenza and RSV. And it turns out a surgical mask can also decrease TB transmission risk. Now, TB, of course, is the archetype of an aerosol-borne pathogen. And you would think to yourself, if you thought about classical theory, you'd say to yourself, oh, well, a medical mask should have really no good at all against TB because it's purely aerosols. But as I think we've shown to you together, a medical mask will decrease your transmissions partly, again, 40 to 60%. And so, in fact, it would not surprise you to learn it actually has some partial protection against TB as well. This is an elegant study. What they did was done inside of a TB ward in South Africa, is that they ported the air on alternate days to different sets of guinea pigs. So on odd days, they had the patients wear a mask, and the ward air was ported to a guinea pig in group 1. On even days, they allowed the patients to go unmasked, and the ward air was ported to a different set of guinea pigs in group 2. And lo and behold, the guinea pigs who were only exposed to masked patients had a 56% lower risk of TB transmission compared to the guinea pigs who were exposed to unmasked patients. So even with this archetypal aerosol-borne pathogen, you can see the protective power of a mask. It is good in reducing risk, but it does not eliminate a risk. What's going on over here? Why is it only good but not great? And the answer is because you don't have a good seal. So this is me on the ward seeing patients, and this is my clinical fellow who's interviewing a patient who's sort of hiding off over here to the right. And I'm standing behind her, and suddenly I realize that despite the fact that she's wearing a mask, I can see her lips moving. And the reason, of course, was because she had a very loose-fitting mask. And so it's not difficult to imagine that if my fellow happened to have an infection, that lots of viruses escaping out of the sides or out of the bottom, it can infect the patient. And conversely, if my patient has a silent infection that's been unrecognized, the patient is at risk of infecting my fellow, again, through the gaps inside of her mask. What's the answer? The answer is a better-fitting face covering, which is an N95 respirator. So an N95 respirator or an equivalent. Here's the analogous experiment that we saw a few moments ago using a medical mask, showing you the amount of particle penetration using a well-fitted N95. And you can see having the patient go through the same motions of bending their head, reading, head side to side, head up and down. The amount of particle penetration is essentially zero, a 98% reduction in particle penetration, in contrast to the medical mask, which we saw only had a 38%. So a N95 respirator is a much more effective blocker of these aerosol-borne viruses. Now, does it play out in human beings as well? Yes, it does. Here's the human equivalent of that particular piece of data over here. This was done in LA County. It was a case control study where they characterized what was your risk of getting COVID as a function of what kind of face covering you wore. Now, if you wore no mask, you had no protection, okay? But if you put on a cloth mask, you decrease your risk of of acquiring COVID by 56%, surgical masks 66%, a respirator, an N95 or a K95 by 83%. So you can see again the progressive protection afforded by better and better levels of respiratory protection. Now you're saying to yourself, well, okay, very nice, but what about these large randomized trials of medical masks versus N95s? Here, I think, is the most recent, and I think probably the best done of these studies. This was 1,009 healthcare workers who were randomized to N95s versus medical masks for the routine care of patients with suspected or confirmed COVID-19. And you can see they found no difference in healthcare worker acquisition of COVID-19 rates amongst those randomized to medical masks and N95s. So does this mean that everything I've told you is garbage? Well, maybe, but the key point over here of this particular study was, look at this. It was limited just to the routine care of patients with suspected or confirmed COVID-19. And as we said, so much of our problem over here is actually attributable to people with asymptomatic or pre-symptomatic unrecognized infections. That's the source of the majority of transmission. So if you're only wearing your N95 respirator for those with suspected or confirmed COVID-19, you're missing the majority of the action as to where transmission actually takes place. You have to be wearing your N95 respirator the entire time, and not only in the hospital alone, but also outside the hospital, in the break rooms, at home, in social events, so on and so forth. Otherwise, you're going to be simply overwhelming any hospital-based signal with the enormous amount of transmission that takes place outside of formal medical interactions. Where do healthcare workers get infected? It's not from patients, by and large, not from patients with known COVID-19. It's either from the community or from their household, or from patient-employee clusters, or from a coworker. It's very little transmission that's actually attributable to a patient with known COVID-19. So if you're limiting your N95 respirator use just to those in whom you've already confirmed COVID-19, you're missing the vast majority of transmission angles. And it's also, likewise, will not surprise you then to learn where is it that healthcare worker clusters occur. It's not on the COVID ward. It's actually everywhere else except for the COVID ward. This over here is a whole genome sequencing analysis of 14 clusters with 117 infections at the Veterans Affairs hospitals in Northeast Ohio. And the majority of clusters, you can see, took place not in the COVID ward, but outpatient clinics, ancillary services like physical therapy, non-COVID inpatient wards, and the emergency department. In other words, settings where you don't recognize a person as COVID-19, and therefore you're not taking full protective measures. If you take full protective measures, you're fine. N95 respirators really do work. But if you're not wearing them, that's where you're going to be exposed and transmit. And so if we go back to this randomized trial of medical masks versus N95s, you'll actually see something quite interesting, which is that if you look at the risk of infection and you break it down by participating country, it was actually quite different. So the odds of ratio of transmission in Canada was almost significant and about threefold higher in those who wore medical masks compared to N95s, and intermediate at the other sites, and there was no signal at all from Egypt. Now, Egypt contributed the majority of patients to this particular study. The other thing is that if you look at each of these countries, what might have accounted for the differences in transmission rates? So this study helpfully reported the community prevalence of SARS-CoV-2 using the baseline seroprevalence rates for each country. And you can see that there's an inverse relationship over here. The higher the seroprevalence, the more COVID inside the community, the less of a signal you saw about the use of face coverings inside of the hospital. By contrast, in countries with very low seroprevalence, what that meant in essence is that those healthcare workers inside the study had very little exposure, if any, to COVID outside of the hospital. So in their instance, they were really only being exposed to those patients whom they were caring for with known COVID-19. And that's where you saw the protective power in N95. By contrast, in countries where there was a huge amount of COVID inside the community exposure, I would argue, far overwhelmed whatever exposure they might have got inside the hospital from known COVID-19 patients. And that accounts for the negative effect seen in those countries. Let's go on to traditional point of dogma number 3. Selected procedures increase aerosol generation, and these procedures therefore merit a higher level of respiratory protection, such as an N95 respirator, a PAPR, and a negative pressure or airborne infection isolation room. Well, what are these aerosol generating procedures? So this is a study back from using SARS-1 data. This was put together by the World Health Organization on behalf of the World Health Organization back in 2012. And this was The question was asking, can you characterize increased risk of healthcare workers getting infected as a function of the kinds of procedures they might have been involved in? And the archetypal procedure here is endotracheal intubation. And using a case control methodology, they were able to identify that healthcare workers who were involved in tracheal intubation had a 6-fold increase in getting SARS-CoV-1 themselves. So the procedure, intubation, appeared to be associated with a higher risk of transmission for healthcare workers. And in the same study, they were able to characterize other procedures that also had a higher risk of transmission, including non-invasive positive pressure ventilation, manual ventilation before intubation, tracheotomy, and cardiac resuscitation. Hence the idea that there are certain kinds of procedures that increase risk and therefore merit additional levels of protection. Now you're saying to yourself, well, hang on though, if you've been buying my argument that basically talking is an aerosol generating procedure and that we're all generating aerosols at all time, what actually is special about these procedures? Well, take a look. Here's an amazing thing. If you actually go ahead and you measure particle emission, aerosol emission during these procedures, you'll find something pretty remarkable. This over here is done with aerosol measurement inside an operating room as you intubate and extubate patients. And now, look at here. You intubate the patient, no aerosols. You extubate the patient, almost no aerosols. Then you ask the patient to cough and you get a ton of aerosols. Now, this observation of finding no aerosol emission despite doing a so-called aerosol generating procedure turns out to be true of lots of procedures. So here is aerosol quantification across a range of different kinds of procedures. Mechanical ventilation, nothing. Non-invasive positive pressure ventilation, nothing. Extubation, almost nothing. Bronchoscopy, nothing. Suctioning, no aerosols. The only procedure that was associated with the increase in aerosol generation was this one, which is nebulizing a medication. And of course, that's because that's what nebulizing is supposed to do, right? But it's aerosolizing the medication, not the patient's emissions. So this is shocking data, I would say, that every one of our aerosol generating procedures, bar nebulization, does not actually generate aerosols. How about using supplementary amounts of oxygen? Same idea over here. You're measuring particle concentrations over here, and doesn't matter how much or what modality you use to deliver extra oxygen, it makes no impact upon aerosol generation. Here's room air, nasal cannula with 4 liters per minute, face mask at 15 liters per minute, high flow nasal cannula at 10, 30, 50 liters per minute, non-invasive positive pressure ventilation, low settings, high settings, no impact on aerosol emission. So if you cast your mind back to the slide I showed you before, characterizing the fold increase in aerosol emission as a function of different kinds of activities, this is where high flow and non-invasive positive pressure ventilation bear out. They are nothing compared to talking, exercising, shouting, forced expiration, and coughing. So how then do we explain this idea or this observation that healthcare workers involved in certain procedures, particularly intubation, did have a higher rate of infection? And I'd say we've seen the answer together, which is that it's not the procedure, it's the patient and the circumstances surrounding that. So if you think about yourself, what is the situation in the SARS-CoV-1 where you might be intubating a patient? Well, you're taking a patient who's an extremist, who's highly symptomatic. You're going right next to the patient's face over there. You're opening their airway. You're manipulating inside the airway. And it might be doing that for a long period of time. In other words, you have the perfect setup over there for transmission. You have a highly symptomatic individual, great proximity, prolonged exposure. Those are the factors that lead to transmission. It's not the intubation per se, but rather it's the necessity of closeness, time, and symptomatology that generates the risk of transmission. So where does this leave us? Where are we now in 2024? Can we toss out our mask over here and move on with life? What do we need to be doing? Well, we are in a much better place now compared to any time in the prior years of the pandemic. This is US weekly COVID deaths. So you can see, thankfully, the amount of deaths has gone down dramatically compared to what we experienced at the start of the pandemic. Same with hospitalizations. Also, I won't say they're nothing, but they're certainly less compared to what they were before during the initial winter surge or Omicron surge over here. We're in a much better place. And of course, the answer is because of vaccination and immunity from acquired infection. Even if you get admitted to the hospital with COVID, you're going to do much better now compared to what you did in the past. These are mortality risks across the pandemic from hospitalized patients, and you can see the decrease over time. And again, as we said, the answer is because the vast majority of the population has acquired immunity in one fashion or another. That's either through vaccination or infection, and for most of us, it's actually a combination of both. And what that means is that with that background immunity, the hazard associated with COVID-19 is now tremendously diminished. Nonetheless, there are still some people who are at risk of adverse outcomes from COVID-19 who is still dying with Omicron despite full vaccination and a booster. And here you can see it's the people at the extreme of high age. And likewise, individuals with selected comorbidities. So particularly those who are immunocompromised. So these are people most likely to die from Omicron despite full vaccination and boosters, combined immunodeficiency, leukemia, severe neurological disease, pulmonary hypertension, on down the list. In other words, there is still a fraction of society who still is at risk of adverse outcomes from COVID-19, and it's people with COVID with immunodeficiency or people with severe comorbidities. And so that might be the subset of individuals who still require additional layers of protection, which we have to bring to bear all the lessons we have learned. And what's, of course, it's so important to recognize is that our hospitals concentrate this exact population: the elderly, the frail, the immunocompromised, people with lots of comorbidities. So I would say it behooves us to take these lessons we've learned about COVID-19 transmission, and the most important place to put them into practice is inside the hospital to protect these patients from harm. Is nosocomial SARS-CoV-2 still in fact harmful? So here is a characterization of the mortality rates from nosocomial SARS-CoV-2 across the pandemic. And yes, there has been a tremendous decrease in mortality rates associated with nosocomial SARS-CoV-2 across the pandemic. But nonetheless, you'll see the crude mortality rates, even here in the Omicron era, still hover around 10%. Now, this is not to say these, of course, are sick patients to begin with, right? And so their baseline mortality rates are not zero, but there are emerging data to show that there's a marginal increase in mortality from nosocomial SARS-CoV-2. So again, we have a crude mortality rate here of 10% for nosocomial SARS-CoV-2, and that does, at least in my opinion, bear our close thought about what we can do to prevent those events. Let me summarize. Risk and protection exists in a continuum. There are factors we've explored together that increase risk. That's things like high community incidence, high viral loads, symptomatology, proximity, longer duration of exposure, poor ventilation, lack of masking, lack of vaccination. There are factors that decrease risk, so low community incidence, low viral loads, lack of symptoms, distance, brevity, good ventilation, mask the patient, mask the provider. The better the face covering, the better the protection. N95 is better than a KN95, is better than a face mask, and vaccines do still work. So if I put this all together, I'll say SARS-CoV-2 and other respiratory viruses are transmitted by respiratory particles in a range of sizes. It's not just droplets or aerosols, it's across the spectrum, but most of them actually are aerosols. Surgical masks decrease transmission, but they do not eliminate it. N95s and other kind of respirators are more effective. Most aerosol generating procedures do not generate aerosols. It's a misnomer. And we do now as a society enjoy high levels of acquired immunity, and COVID therefore is mild for most of us, and therefore we don't have to worry too much about protecting ourselves outside the hospital. But there are still subpopulations at very high risk for adverse outcomes, a 10% crude mortality rate. Hospitals concentrate the small subset of society who is still vulnerable to severe infection and death from COVID and other respiratory viruses, and measures to protect these patients are still needed, particularly when there's a lot of virus circulating inside the community. And finally, I just want to say, stay humble, because if I'd given this talk to you 5 years ago, I would have said the exact opposite on every one of these points. So I've learned a huge amount, and I hope we all do too. Thank you.
Mike, that was fantastic. I had choirs of angels singing while you were talking there, and I mean, I'll pick up on a few points. I actually quite like you were carrying a CO2 meter, and I can also remember going into hotels and thinking, oh, I'll turn on the air conditioning. And within 15 minutes of turning on the air conditioning, the CO2 level had quadrupled. So it was turn the air conditioning off straight away and let's get the window open. But anyway, let's move on to a point that you really took apart the lobe study quite nicely. And how could we actually do any form of clinical study that means that it would be relevant because of all the other exposures. Should we actually just be saying this sort of study is impossible? I think that is there are so many confounders with it that it should never be used. It should never be used in creating a guideline. And yet, if people do literature search, they'll find an RCT, and it could end up in one. But as you said, the other exposures, the potential is so enormous to completely throw it off. Do you think a clinical study is ever even remotely feasible, or should we just stick to physics and say this mask removes more, therefore, if it's well fitted, it will help? What's your opinion?
Yeah, no, it's a good question. It's a tough question. I think that it's very difficult to dismiss a randomized trial because we've been taught, it's been ingrained into us that randomized trials are the highest level of evidence. But those who, of course, do evidence-based medicine spend a lot of time thinking about dissecting the quality of a randomized trial. And if it has important points of bias or of lack of generalizability, then the amount of lessons you can take from it is limited. I think that if you actually wanted to do a convincing study, I mean, I'm not one to say you can't study something, because I think you can. I just think you have to recognize that it's a difficult, challenging study to do. What would you have to do? I think you'd have to incorporate whole genome sequencing into the study. It would be not enough to simply say this healthcare worker did get infected and therefore this mask had no good. You'd have to test the patient as well, sequence that patient too, and show analogy. And in that way, be able to filter out all the transmission events that have nothing to do with the hospital setting or with the patient that they might have seen. In practice, it turned out these studies were most feasible during the early part of the pandemic, when SARS-CoV-2 was still rare. There was not much inside the community, and therefore you could concentrate these events. Or, conversely, when a transmission event or a super spreader event was still extraordinary and made headlines. In a case like that, you can still actually to do these studies. So I think that until then, one is well advised to think critically about these studies and try to think, did they actually address all sources of transmission or not? And if they did, good. If they didn't, then don't rely upon that study. And at that point, you could fall back on your physics. But I don't want to be a nihilist and say you cannot study this.
Okay. That's useful. Now, I just want to make a point that early on in COVID, as you said, that people were being admitted to hospital, and they were studied at that time. Now, when I think back, because I ended up working in an intensive care unit built inside a convention center, these were people quite a bit of a way down the disease pathway. They were over the initial stage. They were now needing respiratory support. And I suspect they were hardly infectious at all at that point. So I suspect that some of the first waves of people in hospital with COVID actually were not at their most infectious, unlike those who now acquire COVID in hospital and therefore are easier, they're picking it up at an earlier stage and therefore are more infectious. How do you even equate that into doing that sort of study as well? Good. Because you'd need to move some people out of the study and keep some in.
Yeah, no, good. So you're pointing out sort of one of the great ironies, which is that we're taught in conventional medicine when we're caring for patients that the sicker the patient, the more extreme measures you need to take for that patient to try to save their life. With COVID, it's actually in with regard to transmission, the opposite message is true. The sicker you are, the less likely, less contagious you actually are. And it begins with us, our recognition that most transmission is taking place from asymptomatic or pre-symptomatic individuals. So people at the mildest phase or no symptomatology phase are the most contagious. As you get sicker, those people who ended up on a ventilator or had severe inflammatory syndromes, it was due to inflammatory reaction to the resolved viral infection as opposed to ongoing virus being present. As an aside, this is a tremendous painful irony. All those things we did to restrict visitors from the hospitals in the early part of the pandemic, and those patients who had to die alone, that was unnecessary. Those patients were not contagious.
Yeah.
Now, thankfully, we have acquired tools that help us to address this, and that's namely the fact that we now recognize that when we test a patient using a PCR, we not only get a positive, negative, we actually get a quantification of virus. And although the correlation between the quantity from different assays and transmissibility is soft. Nonetheless, there is overall a clear association. And so I think what we learned to do over the course of the pandemic to say, don't take into account if the person is simply positive or negative, but look at the viral load. Look at the amount of virus you're recovering from the PCR, and in particular how that's changing over time. And that can give you some sense to where a person is inside this pattern of disease, and therefore can help you to recognize how contagious the person is or not. But to return to your actual question, what's the implication of the fact that most hospitalized patients with severe recognized COVID-19 are not contagious? How does that play into our capacity to study the question of protective strategies? It means that your protective strategies have to be applied to all patients, not just to those who have recognized COVID-19 and severe disease. And
exactly.
Now it's difficult, I think, for people to accept, certainly not to do year-round, all-round. But then we can rest our fact that we've seen that there is an incredibly close correlation between the risk of transmission in the hospital and community incidence. So I think it's very reasonable to say, listen, we don't all want to be wearing masks the entire time. We don't all want to be wearing respirators the entire time. But what we can do is correlate our activities and our protective measures with what's going around inside the community. So when there is a COVID surge or an influenza surge or RSV surge for that matter, that's the time to put on your N95 and do it for every patient interaction, because you don't know if you're an occult carrier, you don't know if the patient in front of you who's in for a fracture is an occult carrier. And so therefore, you want to wear it for all patient interactions, but you don't need to do it the entire time. You can focus that effort just on times when community incidence is elevated.
Yeah. I mean, you made the point also about AGPs and being less risk, and possibly they're being performed on people who are not that risky at that time, as for reasons we've just mentioned. But it's actually the people who are asymptomatic, who, although they may not put out much virus, they're the ones who go to the gym. They're the ones who go to the restaurant, and who goes to a restaurant and talks quietly because everybody's talking loudly. They're the ones who go out singing and shouting, not the people who got symptoms, because they're generally not feeling very well and aren't going to do any of that.
Right.
So I think your point about being careful with people is a good one, wherever they are, I think.
Right. Quite right.
You also made that point about the train, which I thought was quite interesting as well, because we mentioned the CO2 detector. There are some trains in the UK where you can travel on them and the CO2 will be at absolutely normal level. It'll be like outdoor air, fresh air. And I can get a train to London and have no issue at all. And the underground, interestingly, the subway is absolutely fine. And yet I can go on one of the high-speed trains going out of London towards the south coast. And within 10 minutes of the doors closing, the CO2 is at over 3,000, even though there's... So each train would be really quite different as well. So is there some message here for public transport, do you think, a bit more globally?
Well, so I think the bigger question is, I mean, do you need to take protection? Who needs to take protection under what circumstances? So the way I think about it is that I'm fully vaccinated. There are still data showing that even now, circa 2023, 2024, that the vaccine does provide good protection against symptomatic disease, good protection against transmission, excellent protection against severe disease. And so I ask myself in a given situation, what's the cost to me to wearing a mask or not? So I don't want to wear a mask when I'm around my family. I don't want to wear a mask when I go socialize with my friends. And because I'm fully vaccinated and otherwise healthy, I accept the risk of getting COVID or flu or RSV in those situations.
Yeah, me too.
By contrast, if I'm riding on an airplane or on a subway, what have you, where I don't want to talk to the person next to me because I'm there on my own, I actually just want to listen to my podcast or read my book or think about life, there's actually no cost to me to putting on a mask or a respirator at that point. So a crowded bus, middle of winter, heading home, I'm going to wear my N95 respirator, and no problem, no cost to me, and potential benefit. So I think one wants to go through that calculus now. And of course, if I had either was less healthy myself or had loved ones in my home who were at risk for adverse outcomes from COVID-19 by virtue of age, poor immune status, or comorbidities, that would change my calculus as well. So I think this is something that really one wants to customize to personal values, personal health, and the circumstances in which you're proposing to take measures or not. The CO2 monitor is helpful to give you some hard data as to the quality of ventilation. But it's just worth remembering that even with outstanding ventilation, even being outside, the face-to-face sustained interaction, you still can get infected.
Sure.
So if you're trying to be maximally protective, don't rely on ventilation alone.
Okay. Now, you said right at the end, you've learned plenty over the last couple of years, some of it hard lessons, I'm sure. I've certainly learned plenty, and I'm likely to finish my career shortly knowing that I know far less about my subject than I thought I did when I trained in 1990. What was the biggest lesson, the biggest eye-opener for you? And should we really have been listening to people from other professions who work in, fluid dynamics, air dynamics, who knew some of this stuff, but we were in some cases reluctant to listen to them? Should we have worked more collaboratively, do you think?
I mean, hindsight is 20/20 vision, right?
Yeah, sure. Yeah,
but
absolutely.
I think, so I grew up with the Droplet, Aerosol, DOGMA. I learned it from people who I deeply respect and continue to respect, and therefore took it at face value. I was aware of some of the controversy around aerosols versus droplets with influenza, and actually followed some of those studies before the pandemic, including some of the randomized trials of N95 versus masks. And I didn't have enough insight at the time to be able to dissect these studies in their fullness. And so I thought when the Donkovich study comparing N95s versus medical masks came out in 2019, that sort of settled the issue, that there were theoretical considerations around airborne transmission, but the randomized trial didn't show a signal. Only in retrospect do I recognize what I think I went through together today, which is that study had the same flaw as the Loeb study, which is that it didn't account for transmission outside of the care of patients with recognized or suspected influenza. So would I have done well to listen to colleagues from other disciplines? Of course I would have had, but I would have actually been a sort of a standard medical triumphist. And I would have said, until you show me sort of the studies in human beings with randomized trials and transmission differences, I'm not going to believe your theoretical physical considerations. So I would have been just as pig-headed and sort of high and mighty as the rest of us. So I really, we had to go through a pandemic with a tremendous amount of evidence thrown in our faces, and personal experience and professional experience before I think we could absorb these things.
Okay. Well, thank you very much. It's been a nice, frank discussion, and I really enjoyed the presentation. And you probably could have expanded the list of dogmas to a couple of others.
I could have, that's true. But anyway, that's for another day.
Okay. Well, I'm sure Paul will have it back again next year. Okay, everybody, just to conclude this session, I'd just like to mention the upcoming teleclasses that you'll be able to listen to over the next few weeks. April 11th, lessons learned from a failed implementation, yet and more chances to learn from where things didn't go very well, and that's Luis Fabrega Juscavicius at the University of Sao Paulo in Brazil. Social science and infection prevention and control, Professor Holly Seal from Australia. Flexible endoscope processing, focus on correcting key weaknesses, Professor Michel Alpha from Canada. And our usual special lecture for the 5th of May from Professor Didier Pittet from the University of Geneva Hospitals. Thanks to our patron sponsors, without whom teleclass education couldn't be possible, Versi, Virox Technologies, and Gamma Healthcare. And unusually, it's not my dog that's interrupting, so that's really quite good. Thanks again, Mike. It's been a tremendous presentation. As ever, I've really enjoyed listening to you. And to everybody, I hope you enjoy the rest of your day. Thank you for listening.